Positioning Lesson 5 is the shoulder girdle, shoulder joint, clavicle, acromioclavicular joint, and scapula. This is one of the most technically demanding positioning categories on the ARRT because it requires multiple rotation-dependent views and because shoulder dislocations require specific projections to diagnose correctly. 14 minutes. The AP shoulder has 3 rotation variants, and each one demonstrates different anatomy. Neutral rotation. The arm hangs naturally at the side, no deliberate rotation. The greater tuberosity appears in partial profile. The glenohumeral joint space is visible. This is the routine initial view for shoulder trauma. CR. Perpendicular, centered 1 inch inferior to the coracoid process. KVP. 70 to 80. Ishi, 40 inches. No grid for most patients. External rotation. The arm is externally rotated, palm facing forward. The greater tuberosity comes fully into profile on the lateral side of the humeral head. Best view for greater tuberosity fractures. The bicipital groove faces anteriorly in this position. Internal rotation. The arm is internally rotated. The patient places their hand on the opposite hip. The small tuberosity comes into profile on the medial side. Best for detecting the Hill-Sachs deformity, a notch or flattening on the posterolateral humeral head that result from the humeral head impacting the glenoid rim during anterior dislocation. 4 special projections. The registry tests all 4. The Y view, scapular Y, also called the lateral scapula. The patient is obliqued 45 to 60 degrees toward the affected side, posterior oblique. The scapular spine, coracoid process, and scapular body form a Y shape. The humeral head should sit centered at the junction of the Y. If dislocated anteriorly, the head rests on the coracoid. If dislocated posteriorly, the head lies below the scapular spine. Axillary. Infrosuperior axial. Patient supine or seated, arm abducted 70 to 90 degrees. The IR is placed above the shoulder against the neck. CR. Horizontal through the axilla toward the IR, demonstrates the glenoid fossa in profile, Hill-Sachs deformity, Bankart lesion, and the relationship of the humeral head to the glenoid. Cannot be done if the patient cannot abduct the arm. Grashey. True AP of the glenohumeral joint. Patient rotated 35 to 45 degrees toward the affected side. This opens the glenohumeral joint space perpendicular to the CR. The standard AP shoulder is not a true AP of the joint. The joint is oblique to the frontal plane. The Grashey is the only view that shows the true joint space. Transthoracic lateral. Opposite shoulder raised. Affected arm hangs at side. CR. Perpendicular through the thorax at the level of the surgical neck. Used when the patient cannot abduct the arm. KVP. 80 to 90 must penetrate the thorax. Demonstrates proximal humerus fractures and dislocations. Clavicle and acromioclavicular joint. AP clavicle. Patient supine or upright. CR perpendicular to the mid-clavicle. PA clavicle. Patient prone. The clavicle is closer to the IR in the prone position, reducing magnification and improving detail. AP axial clavicle. 15 to 30 degrees cephalic angle. Projects the clavicle above the rib cage. AC joint bilateral. Patient erect, arms hanging at the sides without weights. Both joints on the same image for comparison. Then with weights, 5 to 8 pounds hung from each wrist. The wrist, not the hand. The weight must hang freely to relax the shoulder. Acromioclavicular separation is diagnosed by comparing joint space width between the non-stress and stress views. 72-inch SID recommended to include both joints on one image. Scapula. AP scapula. Arm elevated and abducted 90 degrees. This pulls the scapula away from the rib cage. KVP. 70 to 80 because the scapula overlies ribs and lung tissue. A breathing technique can be used. Long exposure during normal breathing blurs the ribs while the scapula remains sharp. Lateral scapula is the Y view. Both views must demonstrate the entire scapula, body, spine, coracoid, acromion, and glenoid. 4 shoulder trauma concepts that the ARRT tests. Anterior dislocation. 95% of all shoulder dislocations. The humeral head displaces anteriorly and inferiorly. The subcoracoid position is most common. On the Y view, the head lies on the coracoid process instead of at the Y junction. On the axillary view, the head lies anterior to the glenoid. Post-reduction films are mandatory. AP, Y view, and axillary. Posterior dislocation. Rare, 2 to 5%. And it is the most commonly missed dislocation on AP view. 2 signs on AP. The light bulb sign. The humeral head appears round and symmetric because it is internally rotated. And the trough sign, a vertical line parallel to the articular surface of the humeral head. Diagnosis requires a Y view or axillary view. Never rely on AP alone. Classic causes: seizure and electric shock. Hill-Sachs deformity. A compression fracture of the posterolateral humeral head from impaction against the glenoid rim during anterior dislocation. Best seen on the internal rotation AP. Appears as a flattening or notch on the humeral head. Marker for recurrent instability risk. Bankart lesion. Avulsion of the anteroinferior glenoid labrum, the cartilage rim of the socket. A bony Bankart involves a fracture of the anteroinferior glenoid rim itself. Best seen on axillary view. Critical for surgical planning. Increases recurrence risk significantly. 3 shoulder girdle questions. The answer is C, anterior dislocation, head resting on the coracoid process. On the Y view, the 3 arms of the Y are the scapular body, coracoid, and scapular spine. The humeral head should sit centered at the junction. In anterior dislocation, 95% of cases, the head displaces anteriorly to rest on or near the coracoid. Posterior dislocation would show the head below the scapular spine. The answer is B, 5 to 8 pounds per wrist. AC joint stress views use 5 to 8 pounds, 2 to 4 kilograms. Hung from each wrist, not held in the hands. Hanging from the wrist allows the shoulder to relax naturally under the weight, stressing the acromioclavicular and coracoclavicular ligaments. Widening of the joint space compared to the non-stress view diagnoses ligamentous disruption. The answer is C, the Grashey projection, 35 to 45 degree posterior oblique. The glenohumeral joint is oblique to the frontal plane. The standard AP view projects the glenoid end face over the humeral head. The joint space appears closed. Rotating the patient 35 to 45 degrees aligns the glenoid face perpendicular to the CR, opening the true joint space. Lesson 5 complete. You covered AP shoulder in neutral, external, and internal rotation with what each demonstrates. The 4 special projections: Y view, axillary, Grashey, and transthoracic lateral, clavicle, and AC joint positioning, including weighted stress views, scapula projections, and shoulder dislocation patterns with Hill-Sachs and Bankart lesions.